your answers.
Yeah, shall I start? Am I audible? Is my screen
Yes,
visible?
ma'am. Yes, ma'am. Your screen is clearly visible.
Yeah, so I want to open the chat box as well. Yeah, so what is this X-ray? Identify the two signs seen on this X-ray. And what is a clinical condition? What is the type of operative management you would use? And any genetic anomaly you could see with this condition. So yeah, I do see a lot of answers coming. So one thing in this is, right, as you rightly pointed out, it is a double bubble sign that is suggestive of duodenal atresia. But something else which is also there is like a free air, which is like a football sign, and also a ligamentum teres sign, which is suggestive of a perforation. So this is a baby with duodenal atresia. You can also see that the feeding tube is almost going out of the gastric margin. So it is like a gastric perforation. So there is a duodenal atresia, that is double bubble sign with a football sign. So it's a duodenal atresia with the perforation is the complete answer. And the operative management is duodenostomy. And of course, one genetic anomaly which is commonly associated with the duodenal atresia is Down syndrome. So along with duodenostomy, you also need to do a repair of the perforation. So can anybody tell? So this is an MRI of a baby. This is an incidental finding. So can anyone tell what does the arrow point out to? Yes. So what is there in the neck which is important to us? Yeah, so somebody did say the answer, that is lingual thyroid. Yeah, so what is the most common cause of congenital hypothyroidism? And this is one of the thyroid tests which is given. And what is Pendred syndrome? So as lightly pointed out, yes, dysgenesis or thyroid agenesis is the most common cause of congenital hypothyroidism. And where do you see this type of picture? Where the TSH is normal or high, free T4 is normal or low, and the T4 is also normal. So essentially that there is congenital hypothyroidism type of picture, but then there is high T3, FT3 and low reverse T3. So this is one of the rare defects, which is actually called as a transporter defect. I will explain the thyroid profiles in the next slide. And what is Pendred syndrome? Which is due to Pendrin gene, and it is associated, hypothyroidism associated with deafness. So how does thyroid profiles change? That is, you can see that when there is free T4, serum free T4 low and total T4 low with TSH high, it is a type of primary hypothyroidism. Most of the primary hypothyroidism would have this sort of picture, except that when there is peripheral resistance to TSH, where it could be the T4 and free T4 could be normal to low with the rise in TSH. So this one which I want to show you is defects in the thyroid hormone transport. So that shows a similar hypothyroid picture, but then what happens is in this sort of picture, the in the peripheral utilization, the T3 cannot be converted to reverse T3. So T3 would be high and reverse T3 would be low. So this shows that, and now there is upcoming that they also do in congenital hypothyroidism many genetic mutations. So these are some of the thyroid pictures in most of the permanent hypothyroidism. And if there is all three are low, that is T4, free T4 and the TSH is low, you could say that there is central hypothyroidism. Okay. So what is this test? And what is called as a normal pattern? And what do you see in this? Can you describe right and left separately? So Yeah, amplitude integrated electroencephalography, which is a form of compressed image of real-time electroencephalography. And it has two things, that is left side and the right side. This is also called as cerebral function monitoring, where you could use it in babies with perinatal asphyxia, seizures, to monitor for any cerebral dysfunction and also for seizures. Mainly it is used for cerebral function. So what is normal in AEG is that usually the lower border of this graph should be at 5 and the upper border should be at 25. This is called as continuous normal voltage. Whereas in this picture, in the lower picture, you see one of the abnormalities, that is discontinuous normal voltage, that is when the lower border is shifted to less than 5, okay, and the upper border remains stable. The other major abnormality that you see on this electroencephalography is actually seizures. So when there is a sudden rise of the lower border and of the upper border, so you can see that there are gaps in this EEG, there is sudden rise of the lower border and the upper border. It is a description of seizures. So the other two abnormal traces are burst suppression and also isoelectric fat trace. Based on this, you would see HIE 1, 2, and 3. In HIE 1, you would have continuous normal voltage. In HIE 2, would have a discontinuous normal voltage or a burst suppression. And in HIE 3, you would have isoelectric fat trace. The burst suppression in the AEG is different from the burst suppression in the normal electroencephalography. Burst suppression in the conventional EEG is actually classified as HIE 3. So that is about this one. So it's an AEG. So continuous normal voltage. The other thing what we'd also see is sleep-wake cycles. So the left shows continuous normal voltage with seizures and the right shows discontinuous normal voltage with status epilepticus. So what is this X-ray finding and what is the diagnosis? So this, I would ask you to focus on the bones. Yeah, somebody already told the most likely diagnosis and the most likely inheritance and the drug used for management. Yeah, so I got answers from Hema, Nisha, Ruthvi. Okay, so Sukanya. So the X-ray finding is, you can see that there are multiple fractures in different stages of healing. The most likely diagnosis here is osteogenesis imperfecta, and the inheritance is autosomal dominant. And the drug of choice, like somebody said, is bisphosphonates. Yes, we would start it a little earlier, like around 4 to 6 weeks. And the commonly used one is palmitronate. Okay, so the case 5 is a scenario. It's a 40-week 3 kg born to G2L0 mother by LSCS and is born to a second-degree consanguineously married couple. So there is a history of previous sibling death on day 5 where the etiology could not be ascertained, and this baby is found to be unresponsive. So this baby has an ammonia of 474, which is high, pH of 7.2, PCO2 15, PO2 72, bicarbonate 7 with sodium 135 and chloride 91. So also having hypoglycemia and ketone positive. So having hypoglycemia, positive ketone. Yeah, so can anybody calculate the anion gap? I get a lot of answers. So anion gap. So anion gap is sodium minus bicarbonate minus chloride, which amounts to around 20. Normal anion gap is around 12 to 14. So this baby has possibly high anion gap metabolic acidosis. And the most likely diagnosis with ketone positive, high ammonia, and acidosis is an organic acidemia because ketone is positive. So can anyone tell me what are the drugs used for ammonia detoxification? Yeah, sodium benzoate. That is correct. So high anion gap metabolic acidosis with compensatory hypocapnia, organic acidemia, sodium benzoate, sodium phenyl acetate, and L-arginine are the drugs used for ammonia detoxification. And what are the conditions which is vitamin responsive? So one is B12. B12 can be given for methylmalonic acidemia. So that is one of the vitamin responsive organic acidemia. Okay, so can anybody identify this figure and interpret these results? So this is a plot used in meta-analysis. Yeah, so it is called as a forest plot. What is the result of this? Which thing would you see to know which intervention is favorable? So to see which intervention is favorable, you should see the diamond at the bottom. The diamond at the bottom will point to one side. So here, as you can see, that it should not touch the line. It is favoring corticosteroid. Yeah. So, and then there is something here called as I-square. What does it mean? And what is relative risk? So something about statistics here. So I-square is nothing but whether all these studies here are homogeneous or heterogeneous. I-square is called as a test of heterogeneity. And if the I-square is less than 25%, there is no heterogeneity. If it is 20 to 50%, there is mild heterogeneity. 50 to 75, there is moderate. And more than 75, all the studies are heterogeneous. It is difficult to interpret the figure. And what is relative risk? Relative risk is nothing but incidence among the exposed to incidence amongst the non-exposed. Yeah, so this is an ECG. It is showing a heart rate of 242. Can anybody identify what is this arrhythmia? It is also enlarged for you. Yeah. And how do you calculate heart rate in an ECG? What is the formula? And what is the drug used for pharmacological cardioversion? And what is the characteristic of QRS in SVT versus VT? Yeah, so as somebody said, I think many people have answered. Again, Nisha, Rutvi, Haribabu, Ravikant, yes. All of you are correct. The answer is supraventricular tachycardia. And you could use the formula of 1500 divided by RR interval in millimeter, that is small squares, or 300 divided by large squares. The drug of choice is adenosine for pharmacological cardioversion. And when you see QRS complex, it is narrow in SVT generally as a rule of thumb and wide QRS. So less than 80 millisecond duration is a narrow QRS, more than 80 millisecond is wide QRS. Okay. So this is a 39-weeker baby with flat facies and hypotonia with liver 7 centimeter below the right costal margin and spleen. So baby is having hepatosplenomegaly. So you can see that there is a peripheral smear provided below. So with this baby and this peripheral smear and the clinical picture, what is your hematological diagnosis? So no, Gaucher is not the right answer. So this baby has flat facies, hypotonia. Let me give you some more clues. Simian crease. Yeah, so the baby has a Down syndrome. And what is the most common hematological abnormality? So AML is more, in the sense, has poorer prognosis. Something which is more milder is called as TAM, or transient abnormal myelopoiesis. And the cell identified as megakaryoblast. What is a mutation you would screen for, and what is the chemotherapy of choice? The mutation we would screen for is called as GATA mutation. And if that GATA mutation is positive, it is proving that it is nothing but transient abnormal myelopoiesis. And the drug of choice is cytarabine. So this transient abnormal myelopoiesis in many cases is completely curable, whereas in a small percentage, it can progress to acute myeloid leukemia. Okay. So this is another scenario 8. 39-weeker baby born to 3 kg baby born to primary mother by outlet forceps for fetal bradycardia. There is history of prolonged second stage of labor, has poor tone, cry, and requires 2 cycles of positive pressure ventilation. And this is a cord blood gas, which is pH of 6.9, PCO2 55, bicarb 7, and basics is -22. And this baby is found to be lethargic, hypotonic with myotic pupils, weak suck, and moro. What is the diagnosis for this infant, and what is the Sarnath staging? Yeah, somebody rightly pointed out stage 2. Does this baby fulfill the criteria for therapeutic hypothermia? What are they? And what is, yes, that is also correct. HI2. What is the first line anti-seizure medication you would use in neonates? One is phenobarbital. Yeah. And what is a therapeutic window within which you would start hypothermia? And what other organ dysfunction you would assess for? So the diagnosis in this infant is perinatal asphyxia, there is no doubt. And the staging is HI2. So how is it HI2? We will look at. So this is the modified Sarnath staging for neonatal encephalopathy. It is classified as normal, mild neonatal encephalopathy, and severe neonatal encephalopathy. There are 6 characteristics. One is level of consciousness, spontaneous activity, posture, tone, primitive reflex, and autonomic system. So any 3 of the 6 in one would fit it into that category. So our baby was lethargic, had hypotonia, had weak suck and moro, and constricted pupil, has 4 out of 6 characteristics in this group. So this baby would be HIE2. And yes, this baby does fit into therapeutic hypothermia, where the gestation more than 35, birth weight more than 1,800. And there are 2 other criteria we should look at. One is physiological criteria and neurological criteria. Physiological criteria, we have an abnormal cord gas. We also have fetal bradycardia. And neurological criteria, this baby is in HI stage 2. So gestation age, physiological criteria, and neurological criteria. So the drug of choice is phenobarbital, and therapeutic hypothermia needs to be initiated within 6 hours. The other organs, the most common organ, it used to be renal, but now it has been reclassified as hepatopulmonary. That is the most common organ, end organ dysfunction in perinatal asphyxia, followed by renal and then cardiac. So this is a 3-day-old neonate who presents to the ER with severe pallor, purpura, respiratory distress, tachypnea, X-ray showing congested lungs, mild cardiomegaly. He has a huge hepatic mass, and when the peripheral smear was done, had anemia and severe thrombocytopenia. So this is a CT scan of the abdomen, which is showing the liver mass. And in addition to this, the USG showed very high vascularity. So what are the most common hepatic masses in a newborn? What is the diagnosis? The second question is, if this syndrome is associated with low platelets, what is it called? And name a macrolide compound used for its treatment. Yeah, so Dr. Hari Babu has said this is called as hemangioma or hemangioendothelioma. The other presentation would be a hepatoblastoma, which can also present, but then that would be less vascular when compared to a hemangioendothelioma. And the syndrome with low platelet is called Kasabach-Merritt. And the macrolide compound which is used, so usually first line treatments are propranolol or dexamethasone. Macrolide compound is sirolimus or rapamycin. So coming to the last question. So this is a baby who is antelatally diagnosed, born at term, antelatally diagnosed to have megacisterna magna, having labored breathing and stridor, and also periods of hyperventilation, apneic episodes, and nystagmus. So this is the MRI. What do you see in this MRI? Which parts of the brain are hypoplastic, and what is your diagnosis? Yeah, Dr. Sukanya is right. The answer is there is molar tooth appearance. So you can see that this is these are the cerebellar peduncles, which are quite hypoplastic. And you can also see that hardly there is any pons or cerebellum which is developed. You can see there is a megacisterna magna on the sagittal section. So this part is pontocerebellar hypoplasia, which is otherwise called as Joubert syndrome. So these are the babies who would have these periods of stridor and hyperventilation apneic episodes, and also nystagmus. And then if you do an MRI, we could pick up the diagnosis, and of course it is confirmed by genetic mutation. So that comes to the end of my OSCE. Thank you very much. I'll hand over the podium to Dr. Nalina.
Thank you, ma'am. Thank you. The questions were really amazing and it was really useful, I hope, for the resident. And if anyone has any doubts, either they can raise their hands or they can ask in the chat box also. Dr. Aruna Devi, do you want to ask any questions? I have allowed you to talk. You can unmute yourself and talk if you have any question.
No, ma'am, thank you.
Okay. Thank you, ma'am. I think there is no further questions. Now I would like to thank both Dr. Manisha ma'am and also the Dr. Bharti ma'am for joining this session with your busy schedules. And this session was really good. And I hope all the resident, all fellows, it was useful because I think exam is there for in next 2 months. Thank you, ma'am. And Sarita will be sending the assessment form. I request you both to fill the assessment and send it back to Sarita.
Yeah, sure. Okay. Thank you. Thank you, Dr. Nalina.
Thank you, ma'am. Thank you.